cause acute hepatitis. Acute and these are both are self-limited. So usually there is no chronic phase of acute, no chronicity of hepatitis A and E. Both are waterborne disease, acute infectious disease only of the liver, and they are self-limiting. There is no specific treatment available for hepatitis A and E hepatitis. So only thing you have to manage only give them supportive treatment. If there is loss of fluid and vitamin by vomiting or loss of appetite or fever, you have to manage symptomatically. So supportive treatment you have to give by way of IV fluids and dextrose, vitamins. If there is fever, you can give paracetamol to them and adequate rest. So by way of physical rest as well as previously we were saying that minimal food should be offered to them so that if there is nausea, they should avoid taking excessive food. So only limited quantity of food can be given them. Even previously we were saying that hepatitis ho gaya isko, you should not give any oily things. So sabji mein oil chal jayega. Whatever he likes, he can take it. If he can tolerate the food, that food is allowed to him. So no unusual restriction to these patients with hepatitis. Whatever quantity, whatever quality of food he wants to take, if he can tolerate it, okay. Otherwise, stop that food. As for hepatitis B, C and D, so D will always associate B with hepatitis B only, never alone. So chronic hepatitis B, so diagnostic test you see already, variety of tests you have to undergo, he has to undergo, and therapy is in form of, previously it was when no treatment was available, so interferon was used, interferon gamma and alpha and PEG interferon alpha. Nowadays oral antiviral therapy is available, which is comparatively cheaper, well tolerated and very much effective. So interferons were quite effective, but they had side effects. They were injectable. Cost of the treatment those days, even around 15 years back, it was around 3 lakhs per therapy for single person. So 3 lakhs those days, 15 years back, quite good sum money. And nowadays this anticoagul available, tenofovir available, daily one tablet 300 milligram tenofovir you give, and patient is well controlled with this drug. So only I think 3,000 rupees per month therapies, 100 rupees per tablet averagely it is. So at least patient can be saved with little amount of money only, which is quite affordable to an ordinary person. If he is not affordable, he can go and seek treatment from the government hospital. He may get it free also. So tenofovir 300 milligram, there are two salts available. So one is 25 and one is 300 milligram. Both are same only the last salt is deciding the amount of the drug. So tenofovir alafenate will be only 25 milligram. It is not less effective. It is a salt which is required in this dose only. So both are same, equal efficacy. Whatever available you can use it. So if he fails treatment, then only he can go to lamivudine and adenovirus or telbivudine, but these are less effective. So chronic hepatitis C, usually gastroenterologists will go for the genome studies. Type 1 height is 5, 2, 3, 4, 5, 6. So 1, 2, 3, 4, 5, 6. So genotype 1 to 6. So last three you see genotype 1 to 6 effective in all genotype 1 and 6. So you can remember single drug only, this sofosbuvir plus valprotasavir. So this combination is quite good. It will act in all the genotypes of the hepatitis C and quite well tolerated, and mind it that it will almost clear the virus after 1 year, say. While in hepatitis B you can control it, you cannot clear the virus forever. For hepatitis B fevers, no drug is consistently able to eradicate the hepatitis B completely. So you have to go give it indefinitely. Most of the patients you have to continue it indefinitely. The goals of treatment are HBe-AG conversion, seroconversion. If a patient becomes HBe antigen positive, the goal of therapy is to convert into seronegative. Even then, in most of patients you may require continuation of the forever. So reduction in H beta DNA viral load, what we call viral load of hepatitis B, DNA load to the lowest possible level. Again, you remember first line, no drug is consistently able to eradicate hepatitis B virus. There should be normalization of LFT and histologically improvement is there. So these all were previously done, nowadays only, usually only LFT, they follow up with the LFT only. Or VSG engine. Hepatitis B patient, my one patient was there, so she had ascites for 2 or 3 or 4 years. And after 4 years of drug treatment, suddenly ascites vanished, it finished. And patient became quite okay, but still we are continuing the drug. So drug treatment may sometimes come very late. So indication of treatment is high viral load in the presence of acute hepatitis. So when SGOT-PT are more than 3 times and viral load is high side, then you have to start the treatment, and accordingly we have to call the patient every 6 monthly to see for the viral load as well as SGOT-PT levels. Some patients revert to HBe positive again. So HBe antigen, once you give medicine, become negative. Sometime on stopping the medicine, it may convert again to A positive, HBeAg positive. They have also rise in DNA levels, so DNA load again become high, and there is recurrence of hepatitis by way of SGOT-PT and alkaline phosphatase raised again. These type patients require long-term therapy, indefinite therapy. Long-term therapy also required when seroconversion does not occur. So you have to remember that most of the patients may require long-term therapy. Because once you stop them, relapse is quite common. So for hepatitis B and D, there is long-term therapy required by nucleoside and nucleotide analogues. They act by inhibiting the reverse transcription of the pre-genomic RNA to DNA. So there is reverse transcription. Usually DNA convert to RNA, they make copy of RNA, but RNA usually cannot make DNA. But there is enzyme reverse transcriptase which will lead to making copy of DNA from RNA. So these drugs act by inhibiting that reverse transcription. So they differ in efficacy and rate of resistance. In HBe positive patient, they all achieve HBe antigen negative. Lamivudine is usually cheapest one, still used as a first line therapy in many of the countries because it may be less than half the rate of the tenofovir. Problem is resistance development. Tenofovir or anticoagulation is the most potent drug with an optimal resistance profile. That means most of the patients will continue to show response in it. There is no recurrence or there is no relapse of the hepatitis or there is no relapse of the symptoms with tenofovir or anticoagulation. It is recommended as first line monotherapy usually. When HBV positive patient becomes seroconvert, treatment should be continued for at least 12 months and then we have to again check it. Only rarely again negative patient may convert again to positive. These patients may require indefinite therapy. Relapse is common if treatment is withdrawn. Combination of both the drugs are two drugs, oral nucleoside and nucleotide. They are not, combination have not resulted in better result rate. Similar drug, same efficacy rather than two drugs. They are not shown better. There is no advantage of giving the two drugs. So monotherapy is preferred. Drug-induced hepatitis, one of the common among them, which again last time we discussed. We have to remove the drug. Most common usually in foreign countries it is paracetamol, but here any anti-tubercular drug in this part of the world, in our India, anti-tubercular drugs. Again, alcohol is counted as a drug like toxin substance. Again, the alcohol is one of the cause. Other drugs also, any of the drug can cause drug-induced hepatitis. So hemodialysis if needed, if acute overdose or toxin in toxic level it has been taken, then hemodialysis may be done to these patients. NAC, N-star system infusion, paracetamol poisoning or any other hepatitis. He said acute liver failure. So NAC infusion to be given according to dose, according to the protocol. This to be given in ICU. Vitamin K should be prescribed into these patients if PTINR is raised. So because this is vitamin K is the main vitamin which is causing this making of coagulation proteins, coagulant proteins. So if INR is raised, you should give vitamin K injection 10 milligram IV every for 3 days. No mobiles, please. No mobiles. So hepatitis C, just now we discussed genotype 1 to 6. You can remember only one combination, sofosbuvir and valpapatasavir. So autoimmune hepatitis, treatment of autoimmune. So first line therapy is autoimmune. Most of the drugs, common drug is glucocorticoid. These are life-saving autoimmune. Once you diagnose it, it is autoimmune hepatitis. Treatment will be glucocorticoid. So almost every autoimmune disease dose is 40 milligram per kg per day or 1 milligram per kg per day. Gradually reduce as the patient improves symptomatically as well as laboratory profile, that is LFT is improving. You can give glucocorticoid. IV glucocorticoid may be given when patient is hospitalized. So prednisone, IV methylprednisolone is available. Budesonide 3 milligram oral 2 to 3 times a day is equally effective with fewer side effects. Another drug is azathioprine for autoimmune hepatitis. It is very good drug, gradually added after few days, 2 weeks of the steroid initiation, while steroid dose is being tapered. So we shift the patient to azathioprine. We add the azathioprine and we gradually reduce the steroid dose. So it is to be given 1 to 2 milligram per kg body weight per day. Mycophenolate mofetil, very good drug, latest one with least side effects. So it is good for maintenance therapy. Should only be steroid. Once LFT are normal, then only you can start mycophenolate mofetil, and dose should be individualized. What dose suits him or what is good for his disease profile, we have to give. 250 and 500 milligram is available. So cirrhosis as such, we have to treat only complications. So last time we talked what cirrhosis can do. So it can do varicose hemorrhage or ascites, and there may be SBP, sometimes hepatorenal syndrome. There is renal insufficiency, patient may go into encephalopathy, or patient may develop jaundice. So portal hypertension, most common complication is variceal, development of varices and their potentiality to bleed at any time. So it commonly lies when the location is around 3 to 5 centimeter GE junction from the gastric. Rectal varices may also develop there in these patients. So when they develop, when the total pressure increase to more than 10 to 12 millimeter of mercury, when more than 12 millimeter, they are prone to rupture. So there is grading of varices, how much varices are present, plus how much prominent they are on looking. Grade 1 to 4 there are, but at this stage you should know that there are varices, they are using longitudinally running veins in the lobe near the floor GE junction. So once they visualize through endoscope, the endoscopist or the gastroenterologist will suggest for treatment of this. So because already we have put the endoscope, so better by ligation, band ligation we say, and second is the sclerosant injection. So sclerosant injection, previously it was commonly used, so one bone was injected by injection through endoscope only. Nowadays totally almost band ligation. Almost. Unless patient is not being getting okay, then they will try this sclerosant agent. So by that endoscope, they will put the endoscope mouth or the camera part near to the varices. They will press a button, it will suck in the varices. एक वेसल उसकी वेन जो है अंदर सक कर लेते हैं स्कोप के अंदर, and there is automatic a gun nearby. They will push the gun and the band will ride over the vein. So they will suck the vein inside and they will fire the gun with a rubber band, जैसे rubber band ही होता है rather. So it will be put on the varice. So this will cause coagulation and there will be fibrosis development within 1 week. So this band ligation is quite common. Bleeding usually manifests, as hematemesis, later on melena, or sometimes both. So medical therapy will be beta blockers. Classically it was non-selective beta blocker, propranolol. According to nowadays, but what we find here, most of the patient will come in SBP, but systolic BP will be around 100. So even we are very conservative in giving treatment of androl. Very conservative, that means 10 milligram BD will start. If BP is more than 110 or 120, then we can start the dose 20 milligram BD. You can go up to 160 milligram per day. So जितना ज़्यादा डोज दे पाते हैं, if you are able to give more dose, उतना ही प्रेशर उसमें पोर्टल वेन में कम हो जाता है, तो लेस चांसेस ऑफ ब्लीडिंग. Secondly, patient who is bleeding, they should be prophylactically given IV antibiotics. This is because to reduce the blood is a good medium for growth of any bacteria. So one should give antibiotics so that there is no growth of bacteria in the bleeding part. जहाँ ब्लीड आपका गेस्ट स्टोमक में गया, नीचे कोलोन जाएगा अपने स्मॉल इंटेस्टाइन, लार्ज इंटेस्टाइन, so there may be development of bacteria. So to stop it, we have to start immediately antibiotics. Secondly, we have to start some vasoconstrictive drug. So terlipressin is nowadays very much in use. So terlipressin should be given if active bleeding is there. Again, blinding or sclerotherapy to be tried in this patient. If nothing is working, then balloon tamponade. Balloon tamponade. Why black steel? One is catheter is there, balloon is there. I'll tell you name just now. Tips also can be advised to these patients. That is transvagal protostomic shunt is to be put through the surgically. Really, esophageal transaction to be advised. So, what is the management of bleeding? We will see IV fluid to replace the extracellular volume. The BP low आ जाएगा एक बार तो fluid देखे अपन कहाँ सा है. Bleeding more, we have to replace blood. Vasopressin, terlipressin to reduce the portal pressure. So, acute bleeding and risk of early bleeding is less there. Prophylactic antibiotic to reduce the incidence of SBP development. Emergency endoscopy to confirm variceal rather than ulcer bleed. कोई और चीज तो नहीं bleed कर दी अपन terlipressin दिए जा रहे हैं तो we have to confirm it sometime. Variceal bed ligation. If it is bleeding, already we see the large varices there. Whether it has recently was bleeding or it is liable to bleed, we have to immediately put a band so that there is no chance of rebleeding. Proton pump inhibitors. By IV infusion of pantoprazole, we can prevent the peptic ulcer also. Phosphate anemia. तो जितना भी ब्लड इसमें आया है, it may again induce hyperammonia in the blood. So there will be development of encephalopathy. To prevent this, तो जितना भी blood है, immediately we have to wash the gut through either lactulose और फॉस्फेट एनीमा. उससे जितना भी प्रोटीन एक्सेस जा रहा है, ब्लड इज अगेन प्रोटीन मोस्ट ऑफ इट, सो इट विल कॉज डेवलपमेंट ऑफ एन्सेफेलोपैथी. सो टू रिड्यूस दिस वी हैव टू क्लियर दिस ब्लड अमाउंट. सो प्रोटीन अमाउंट वी हैव टू क्लियर इट बाय वे ऑफ गिविंग इन्वेसो 3 to 4, 5 लूज मोशंस पर डे इज द टारगेट. So if suspected variceal hemorrhage, start terlipressin and prophylactically antibiotic. Urgent upper GI endoscopy. If varices is present, yes, then variceal bending or sclerotherapy, that is sclerosant you have to push. If we cannot see any varices, then we have to stop the terlipressin also. Look for the ulcer. If there is any peptic ulcer bleeding, then we have to start pantoprazole IV infusion. If there is hemostasis done, then continue terlipressin for 72 hours and beta blocker as secondary prophylaxis. So again, if the pressure inside the portal vein is decreased, so we have to give beta blocker. Endoscopic bending program should be instituted in this patient. Call multiple times the patient till the varices are disappearing. And if there is no hemostasis, then we have to further endoscopic therapy. Balloon tamponade may be tried. So sense taken Blackmore tube is to be tried in these patients. Balloon tamponade. Again, there is bleeding maybe from the portal gastropathy. With the portal hypertension, gastropathy, there are hexagonal patches development inside the stomach. So when you put endoscope, no varices, you can see the stomach. If it is present, it is indirect evidence that there is portal hypertension present. If anything bleeding point you see, you can put sclerosant there because you cannot bend the patches. Patch के ऊपर आप बैंड नहीं चढ़ा सकते. Stomach will come and it will rather make harm to the, because no vessel is usually visible. If vessel visible दिखते रही छोटा point, we have to put the sclerosant. वो भी hyperemic gastric patch दिखाई देगा hypertension. we have to put sclerosant. Due to this, there may be iron deficiency anemia, so replace the blood, and later on you can start the iron therapy or IV injection. Again, to decrease the pressure or reduce the portal hypertension, gastropathy, again we have to start propranolol, if not already there. Sclerosant injection, gastropathy, again, if ineffective, again TIPS procedure can be undertaken. Finally, TIPS is there, shunt to make shunt, protostemic shunt. So ascites, again we see that ascites is developing due to portal hypertension. We already discussed the pathogenesis. So spontaneous bacterial peritonitis, already last time we discussed. So this patient with the ascites, they develop, it is again complication of cirrhosis with ascites. So they may come with the pain abdomen, there is rebound tenderness, there is absent bowel sounds, and sometimes fever also, count will be high. So abdominal signs sometimes may be absent, rather hepatic encephalopathy and fever may predominate. So we are thinking about only meningitis or encephalitis, but it may be due to SBP. It may be due to SBP. So SBP, sometimes you may not find any complaint of pain, abdomen, there is no tenderness, but when you say for the cytological examination of this ascites, you will find polymorphs are more than 250 cells per ml, microliter rather. So this is mostly usually E. coli and Streptococcus induced, and usually it is monobacterial only. If polybacterial, it is due to secondary infection. If monobacterial, chances it is spontaneous bacterial peritonitis. So immediately we can start antibiotic therapy. Most common usually we are using ceftriaxone. If no need, you can proceed further for peptides, that is piperacillin tazobactam, or sometimes even meropenem. And prophylactic to give these patients with ascites, once you have developed SBP, now okay, you are discharging, you can put the patient on prophylactic quinolone, that is ciproflox, you can advise them, prescribe them. So ascites, how to manage ascites? Again, we have to see for the ascitic SARD ratio, because again fluid collection, we have to decrease the salt intake, as well as if patient hyponatremic, fluid intake also to be restricted. So NSAID should be contraindicated because they may cause again renal failure in these patients. ACE inhibitor for the same reason should be avoided. So in these patients, whenever you try to make a drainage of this ascitic fluid by paracentesis, it will reappear the next day. After 2-3 days, again same quantity will come. But this is because the hydrostatic pressure is again more there inside the abdomen, so more development of fluid. So how to reduce this? Simultaneously we have to infuse albumin. So oncotic pressure of the serum is increased, so no more filtration of the fluid from there. So always need to drain this ascitic fluid by putting IV albumin. So 100 ml bottle, 20% available, quite costlier for general public, it is around 6,000 to 7,000 rupees. So only then you can drain the fluid. When the redevelopment of fluid is slow, otherwise within 2-3 days उतना ही मोटा हो जाएगा पेशेंट का पेट. Again with the Lasix and spironolactone, that is spironolactone, you can start spironolactone. These patients, we start from 25 milligram, you can go up to 100 milligram BD. So 25 BD से start करके whatever response you get, you want to have, you can go up to 200 milligram per day. Maximum is usually 400 milligram per day, but we are not going farther than 100 milligram BD in our wards. So again, Lasix, 1 tablet 40 milligram, maximum 4 tablets you can try according to the response you want to get from patient. So goal of weight loss should be Patient should not lose more than half to 750 or 700 gram per day if patient is not having edema feet. अगर peripheral edema नहीं है उसको, only ascites, so for simple process में it is suggested you should not take out much of the fluid. So weight loss should be not more than 700 gram per day, otherwise patient may go into encephalopathy. Patient with massive ascites and respiratory distress है, उसका इतना ज़्यादा पेट फूल रहा है कि डायफ्राम तक ऊपर आ रहा है, he is having difficulty in breathing, तो लंग को एक्सपेंशन के लिए जगह नहीं मिल रही है. तो in this patient it is suggested that you can take out 5 liter, but never go for that. You can maximum 2.5 liter, that too on the cover of albumin infusion. Okay. So concomitant IV albumin 6 to 8 gram per liter of ascitic fluid देना चाहिए हमें. Hepatic encephalopathy. Sometimes we go, patient present to us in the confused state of ascites, alcohol पीता था. We know that hepatic failure patient है, cirrhosis हो गया, इसके पानी भरा हुआ है. Patient comes in encephalopathy, is confused, sometimes drowsy, sometimes uncontrollable. जैसे psychiatric patient होता है ऐसे ही. तो there is special protocol. So first thing is ask the patient, motion गया कि नहीं गया, उसको टॉयलेट हुआ कि नहीं, और 2-3 दिन से. If his answer is no, immediately start lactulose. Lactulose enema daily, lactulose 15 to 30 ml 3 times a day. Target is 3 to 5 loose motions per day. 3 to 5 loose motions per day. तो उसका जितना भी टॉक्सिन मटेरियल प्रोटीन जो उसके बॉक्स में है, अमोनिया बन रहा है उसका प्रोटीन का, that will be washed out from the stool. So his hepatic encephalopathy will reverse. Immediate effect will come. Patient का जो मोशन पास हुआ 2-3-4 घंटे में patient will be stable. So always start lactulose or any by any way you have to give enema so that immediately is bowel movement is there. So second drug is rifaximin. This is a well tolerated, non-absorbed antibiotic. So stomach मतलब नहीं GI नहीं पड़ी रहेगी, लेकिन it will act by reducing the bacterial content of the bowel, shown to be effective. So again, bacteria have been incriminated in the development of hepatic encephalopathy. Whatever the stool there, they will generate more growth of the bacteria, and these may start producing more of the ammonia, and again there is hepatic encephalopathy. To reduce it, you have to give antibiotic also, that is rifaximin. So ये 450 या 400 मिलीग्राम TDS 600 मिलीग्राम की भी आती है. तो opioid and sedative should be avoided because most of them are being metabolized by liver. Only fewer drugs are available. One is oxazepam, previously available very freely. Nowadays it is not available. Oral tablet. So you have to try again Serenase, haloperidol injection. So patient comes in psychotic state, he is uncontrollable. You have to give injection Serenase because this is quite safer in these patients. It will not induce drowsiness to them. Protein intake should be limited up to 80 gram per day. Replace meat protein with the vegetable protein. So if he is taking non-veg protein, so reduce to it change to vegetarian protein. Another therapy is L-lanthanum, L-aspartate. This injection available, and this is recommended in encephalopathy, and 6 ampoule containing 5 gram of the drug. This can be tried in these patients. And definite therapy is again liver transplantation.